a minute always seems like forever when you're waiting, just staring at other people on the screen. But thanks very much. We've got plenty of attendees on now, which is fantastic. So welcome everyone to the next EMIS Live series webinar. My name is Jamie Cole. I work within the EMIS Partners team. I'm delighted this afternoon to welcome one of our elite partners, Synapsis. They have a fantastic communication tool platform that enables authorised NHS users to communicate and seek instant advice and guidance. And this is, of course, against a backdrop of a COVID legacy, a backlog of wait lists and elective care treatments, which I'm sure we'll be hearing more about shortly. Just a little bit of housekeeping. We will be recording the session today, and that will be shared back out to the attendees. And obviously feel free to share with colleagues who wish to have a look. All the attendees will remain on mute throughout. So to ask a question, and please do ask questions, you should see a small question icon probably in the top right corner. It may appear somewhere different depending on what update you've got with Teams, but in there's a question box. Simply type your question there. We'll have a number of colleagues on hand to answer those, and if there's time at the end, we'll also be able to sort of read some of those questions out and handle some of those questions directly. We'll also provide an update in the email afterwards with those frequently asked questions, so any that we don't get to immediately, we'll provide a response afterwards. So without further delay, I'm delighted to hand over to Owen Hughes, who will give you a quick intro to himself and the other speakers. Over to you, Owen.
So great, thank you very much, and welcome to the webinar. As Jamie has said, we work very closely with EMIS, and it's a pleasure to be hosting this webinar jointly with them. So thank you very much. And this webinar is about dermatology and how the pandemic has changed dermatology practice across primary and secondary care. My name's Owen Hughes. As I said, I'm the CEO of Synapsis. I have a clinical background and I'm an ENT surgeon, but I've been focusing on Synapsis for the last few years. And I'm really pleased to be joined today by two people who have really been instrumental in developing Synapsis for dermatology across Gloucestershire. So first of all is Chin Whybrew, who is a general practitioner with a specialist interest in dermatology and has been instrumental in developing resources for educating beginners about how to use dermatoscopy and so on. And also Dr. Will Porter, who's a consultant dermatologist at Gloucestershire Hospitals NHS Foundation Trust, and he has a specialist interest in skin cancer and also paediatric dermatology. So just to give you an idea about the structure of today, so I'm going to start with just a brief presentation just to give you an overview of Synapsis and us as a company, because some of you may not have heard of us. We'll then give you a short demonstration of how Synapsis is used and how it works with EMIS in particular, and then we'll go into a longer period of question and answers with Chin and Dr. Porter as well. So about Synapsis. So Synapsis is really a platform that makes it easy for clinicians to communicate. So typically those clinicians work in different organisations, so GPs or paramedics or nurses in the community. But increasingly we're being asked to help with communication within organisations as well, so within a trust or across primary care. And we support that communication both in real time and asynchronous. So dermatology is a perfect example of how asynchronous communication really delivers benefits. Synchronous communication, so over video or over voice more commonly, is very useful for unplanned care, so things like paediatrics or acute medicine or trauma and orthopedics and so on. And we're doing that across now more than 20 services in Gloucestershire and elsewhere. And the way Synapsis works, really, it's built into Synapsis is the idea of pathways. So what is the clinical problem that, for example, the GP is facing? And that decides, that clinical problem really decides, one, the acuity of the problem. So is this something that needs to be dealt with right now? Or is it something that can be dealt with, within hours or within 24 or 48 hours, for example? So pathways is really integral to the way Synapses works. An example of pathways would be, chest pain or query DVT or abdominal pain in a child or a skin lesion or a rash, for example. The pathway also determines who is the appropriate person to give that advice. Who within the team in secondary care, for example, has the ability to give effective advice for the GP, both clinical, but also how you deliver that advice locally within the health economy. And to support that, Synapses allows the secure sharing of documents, so any type of documents, so images or videos or DICOM, which is radiographs, or even parts of the medical record. And then on top of that, Synapses allows commissioners and managers to see what is happening in terms of communication. So what communications are happening, who's involved in those communications, who they're about, and what the outcome of those conversations are. And that is really powerful insights that they can use to refine their pathways or develop new pathways. So it's a really powerful system that can help across integrated care systems. As I said, we work really closely with EMIS, so we have a very good integration, both read and write, with EMIS Web and EMIS Community. But we also integrate with other systems. So we've got the same level of integration with System 1, and now we have an integration that's soon to go live with ERS, so that advice and guidance can be converted into appointments through ERS, which is really powerful. And we're working with a number of areas across England, the southwest and the east, and Cheshire and Merseyside, for example. We're also with a lot of different organisations, so not just GP practices and trusts, but ambulance trusts, out-of-hours providers like Practice Plus Group, insourcing groups like SILA, and also the Ministry of Defence, where they have bases, and we're on a number of frameworks. So we'll go on to talk about kind of the detail of the impact of advice and guidance for dermatology, but the data that we have is that 70% of advice, 70% of cases through Synapses for dermatology, for example, is managed with advice only. So they can be discussed and the patient doesn't need to be seen in secondary care. One of the areas that we're particularly interested in, and we will speak to Dr. Porter about, is this selection of the right patients into high resource environments like a 2-week wait pathway. And the see and treat services that they have in Gloucestershire. So that's kind of an interesting area that we'll touch on. I'll ask Bill Porter and Chin Whybrew to introduce themselves. So Chin, do you want to start?
Yes. Hello, I'm Chin Whybrew and I'm a GP in Cheltenham. And I am a jobbing GP and I use Synapses from the GP viewpoint, and I send loads and loads of dermatology advice and guidance, as Bill will attest shortly, but also use it for, so within Gloucestershire we also use Synapses for all of our acute medical referrals in real time. So we're using it for quite a lot of other specialties as well as the teledermatology, which is a huge advantage because it means that all the GPs know how to use it.
Great, thank you, Chin. And Bill, do you want to introduce yourself?
Sure. Hi, I'm Bill Porter. I've been a consultant here for about 20 odd years. And in terms of A&G, we use about equal Synapses and ERS at the moment, but the numbers are always changing. That's about all I want to say.
Great, thank you very much. So I guess I thought I'd start kind of at a pretty high level, I guess, and just to let everybody have an idea of how COVID has changed the way that dermatology is delivered in secondary care and primary care. So I thought I'd start with you, Bill, and just give people, because a lot of people listening will be GPs or practice managers, so they may, obviously they're extremely busy, they may not have a full appreciation of what it's like now in secondary care for dermatology, both in terms of the workload, but what the things that you're having to do to try and manage that. So if you could give us a flavour about that, that'd be useful. Thank you.
So we about probably 2 years ago, we had a waiting list of about 3 or 4 months, and since the COVID crisis, it's gone up to about 9 months for a routine referral now. So there's been obviously a large backlog established. In terms of A&G, I'd say that 2 or 3 years ago we were doing about 200 or 300 a month, and we're now doing more like 800, and we are also now triaging using ERS in particular, up to about 800 of those a month as well. So our workload, online workload, has gone up enormously since the crisis. In terms of clinical work, we are still seeing people actually in much the same way. We did try for a while to do teleconferencing with patients, but it was awful. You know, dermatology requires you to see a lesion if you haven't got a photograph. A few people in my department have been taking letters and looking at photographs sent by GPs, but it's a quite long-winded way of doing things. So largely we've stayed much the same in the way we have processed our patients. We are seeing the same sort of numbers, we've just got a longer waiting list, but we are seeing them face to face and have been since last summer. The only reason we had a short blip was because dermatology was closed down and we had to go and work on the COVID wards for a while. But the numbers have gone up, the waiting lists have gone up, and I guess the only thing I would say is that whilst our waiting list has increased in terms of face-to-face referrals, I think it would have gone up to about 1.5 years if it weren't for A&G in some form or other. So not a huge amount of change, just more pressure.
Yes, and one of the things we spoke about before was these see and treat clinics. Are they something that existed before COVID? Can you kind of explain what that is like and how those clinics work?
So on a daily basis, we have a 2-week rule clinic, which is essentially a see and treat clinic. And we were doing it before COVID, and it's staffed by about between 4 and 6 or maybe 7 clinicians. There'll be 1 or 2 who are doing the surgery, and the rest are seeing patients, lists varying from 8 to 12 patients, depending on experience and seniority. And if a patient comes in with a cancer, and we're talking about SCC and melanoma on the whole only, or something to diagnose, they get the surgery on the day. So we might see 70 to 80 patients in a clinic, of which maybe 7 to 10 will have direct surgery. If there's another 10 that need surgery, they get put on a waiting list, which is about 4 to 6 weeks at the moment, and the rest of them are discharged if they have benign lesions. But since COVID, has that changed much? Not a lot. We've got more staff as a result of COVID, actually, so we're probably having just larger clinics.
And that's 70 to 80 clinics per 70 to 80 patients per clinic. So that, and a clinic would be half a day.
Yeah, so that'd be one session. Yeah. And
that's every day of the week.
I think maybe one day a week is off, but we get about 400 2-week rule referrals a month. So maybe more, maybe 600 now. So it's and not every clinic is 70 or 80 patients. Some of them are only sort of 30, and you take into leave as well, take into account leave and things like that, it goes down. But last Monday there were 6 clinicians with a list of 10 to 12 patients each. So that would be a big one, but yeah, perhaps the more modest one would be 30 to 40.
And what proportion of patients are diagnosed in that clinic? Get their biopsy and get a result. What proportion are you able to actually treat them in that clinic, would you say? Well,
in Gloucestershire, the averages are pretty good, but about 20% of the patients attending the 2-week rule clinic, as opposed to 10% in other areas of the country, will have skin cancer. So 80% won't have cancer. Yeah. No one gets an on-the-day diagnosis because we have to rely on the pathology, which is a turnaround time usually of about 2 weeks for a melanoma or SCC. We'll give them an idea on the day of what it is, but it takes about 2 weeks till they get a diagnosis and onward management.
Great. Thank you very much, Bill. That's really useful and really interesting. The kind of how it's delivered in secondary care. So, Chin, how have things changed? Have things changed much in primary care?
Yeah, I think it's fair to say that primary care had some fairly major changes, although some things obviously have stayed the same. What we're seeing much more is patients are much happier to send us photos of all sorts of things, skin lesions included, and that is helping us to triage which patients need to be seen face to face by us, which patients can be referred to dermatology without us actually seeing them. And I know that Bill doesn't approve of this. There are very few patients in which this is the case, though. So it's basically if someone sends you a really good clinical photo of an obvious SCC, you know there's no point seeing the patient, you know they're going to need to go up. But that's pretty much the only thing that we would do like that, because any pigmented lesion is going to need dermoscopy, and all the practices locally have a dermatoscope and have had training in how to use one, and so we can do that, and we would see patients and sort of review them like that. So the main thing that's changed with us is that patients are sending us their photos, and we are using the photos that they are sending us in order to triage whether we need to see them face to face at all, because some of them they'll send you a photo, it's really obvious what it is, you can just deal with it all over the phone. But we're still seeing them face to face clearly if they need to be seen, and we're still doing dermoscopy. We're still taking dermoscopy photos and sending them up for advice and guidance or interpreting them ourselves. So yeah, but the thing that's changed most actually with the photos is enabling me to see, for example, someone says I've got a bleeding mole on my back. If they send me a photo and it looks like a SEB-K, I actually want to see them in a week or two's time once it's had a chance to heal, not today and then in a week or two's time once it's had a chance to heal. Whereas if they send me a photo and it looks like an actual bleeding melanoma on their back, I want to see them today. So that has been a huge positive and a really good thing that's come out of it, and is helping us to just be more sensible about how we're operating our appointment systems.
Just so we have an idea, what is your role, say, within your practice or within the ICS in Gloucestershire for dermatology? Obviously you have a clinical interest, but what does that actually mean in practice?
In practice, I am a jobbing GP. So my only role is in general practice. But the other thing that I do is I teach dermatology and I teach dermoscopy across our CCG and several others. I think there are a few other CCGs represented here today. I'm sure there'll be some people in the audience who've heard me spouting on about dermoscopy from time to time. So yeah, so most of what I do now is teaching dermatology and face-to-face general practice, but I'm a jobbing GP first and foremost.
And but is the patients that you see, do your colleagues send you dermatology cases more likely, or will you see the same proportion as everybody else? How does that work?
So I work very part-time, and I work very part-time in a very large practice. And so I can't do all of the dermatology for the practice. So I see my own patients, and I also see internal referrals that my colleagues have sent to me. Most of them come to me because reception divert them to me. I have a healthcare assistant who does dermoscopy. So if a request comes in on an e-consult, for example, they will often get booked in for the healthcare assistant to take the photos and the dermoscopy photos. And then I have a list, which is basically just an admin list, appointment list, of sort of internal advice and guidance stuff, which is mostly the dermoscopy photos that the healthcare assistant's taken, but also photos that my colleagues have taken, photos that nurses have taken, anything anyone wants to ask an opinion on, basically. But we're an unusual practice, I have to say. That's not a normal setup, and I do quite a lot comes to me that would otherwise go to the advice and guidance service in some other format.
So they come to you as kind of first line advice often, rather than go to secondary care. So
yeah.
And can I ask you how has kind of Synapsis and advice and guidance impact on your practice then, and your colleagues' practice? How is it? What difference has it made?
I think one of the one of the things that I would say about our practice is that we've been using advice and guidance in some guise for longer than advice and guidance has been a thing. So I've been emailing clinical questions to Bill and to various other dermatologists and dermatology GPSIs ever since I moved to Gloucestershire 15 years ago. And so when advice and guidance became a thing, that was something that I was really keen to use and do use and have used. And it's been fantastically helpful for patients in terms of not just should I be referring this person, but I want to refer this person. I know you're not going to see them for 3 months. What can I be doing in the meantime to keep them going? Because I think that's a really important thing. And then some of them, of course, is just see if it gets better and it may not need a referral at all. Initially, that was when it was first set up as a thing. It was set up on ERS, which is really quite unwieldy to use. And the problem with ERS is that in most practices, it's run by the secretaries and the GPs don't set up the appointments on it themselves. And it is a bit of a pain and it is quite awkward and there's lots of clicking and it's very slow and you spend a lot of time watching the circle of doom. And so when we had the option, the other thing with ERS is that when you've done your request and the reply's gone through, you have to go back and physically look for the answer. There's nothing that sends it directly to you and there's no integration with the patient's notes. So you've got to go and look for the answer, download it and then upload it into the patient's notes. So then when Synapsis came along, that was great because one of the big things is that it's much easier for the GPs to use, partly because we're using it already for all our acute referrals, so everyone was used to using it, partly because the PDF comes into the practice in the same way as all the other letters that come into the practice, so it ends up in your inbox. So you can go and look for an answer, but if you haven't looked for the answer, it will find its way to you, which is a very important thing and a very useful thing. And I can see that someone's asking that in one of the questions as well.
Exactly.
And the other massive improvement has been the Synapses Toolbar, because originally we were having to input the NHS number and date of birth for every patient. And with the toolbar, you can just click on it and you're there. And that makes a huge difference. It just makes it so much quicker and easier. So yeah, love it, I have to say. I think it's great.
Great, thank you, Jen. And from your point of view, Bill, I guess you've got a benefit of a long history as well of doing advice and guidance. How has Synapsis changed things for you?
Well, ERS, I agree with Chin. ERS is quite clunky. You've got to open every image separately. You can't then view them at the same time. Then you've got to open the letter separately. So Synapsis probably halves the time compared to ERS for us to look at the whole package. And it's a much nicer template to look at everything on one page. And the drop downs are better. And the whole thing is just slicker and more modern. And as a secondary care clinician, I think all my colleagues would agree with this. It is far, far easier to use, and therefore you can do more with it and see more patients. Great,
thank you. So I was just going to spend a bit of time going through the questions that we received. So one is around the filing back into the practice that Chin you touched on, and the question is basically, do reports come back to the practice via document or direct into the patient record? How will practice secretaries know that report has come back if it goes direct into EMIS? Well, that's a very good question. So there's a couple of ways to file back, and it depends on how the practice works. So we can file directly in, certainly in System 1, and some people prefer that, to have the record in the patient record automatically, but we always send it back to the practice via the system that they use to handle all of the communication. So that can be, via nhs.net or via the mesh now we can send as well. Also, we have an integration with Docman, so we could send it via Docman as well, or send it to Docman in another way. But yeah, that's a key thing. So not only getting the report back to the clinician who sent it, but it has to work with the mechanisms of the practice. Chin, do you want to say any more about that, or you?
No, I think it's a really important, it's a hugely important point, and that's a major advantage of Synapsis over doing it in ERS, because it is that extra level of safety net. If I put an advice and guidance request in and then I've gone off sick, no one would know that it was there in ERS, whereas in Synapsis it'll come into my inbox and whoever is covering my letters will see it, so it will be seen.
Great, thank you, Chin. Another question around a similar subject is, how do you get a problem set for this in EMIS? Would not appear if I search for all dermatologic conditions. So I think this question is around coding, so SNOMED coding of the reports, and Synapsis can do that. So we can file back not just the text like Carl showed you, but that text can also be SNOMED coded or read coded. They're kind of one and the same now, I think. And then you can then do a search and you can find those cases that way. So that's powerful. I don't know whether you've done any of that, Jim, in System 1, whether you've done or you've set up, and do you have any searches that you've set up using SNOMED codes?
No, and I have to say that's not a way that I would normally use my clinical system, if you see what I mean.
Yeah. Okay. So the next question is can you trigger Synapsis Advice and Guidance from within a consultation? So yeah, so you can use the toolbar to launch in context, basically, and do it that way. And Bill, there's a question for you around 2-week wait referrals, and I guess selecting patients into these see and treat clinics. How does that work alongside advice and guidance? How do you use advice and guidance in that context?
Well, the patient, there's two ways. At the moment, we use ERS to vet letters, and you can, if you have a letter and it's attached with a photograph is attached, we can bounce that back to the GP with, no, this shouldn't be an urgent or routine referral, it should be a 2-week rule referral. They then have to do a 2-week rule referral form. If you get a referral through ERS, it's exactly the same. You have to bounce that back with a text message to them. You can't turn ERS into a 2-week rule referral at the moment.
Yeah.
Ditto with Synapsis, but you do have a drop down saying, no, the outcome of this should be a 2-week rule referral. Ideally, what we want is we see the images, either advice and guidance or in triage, and then we select directly from that, either advice back to the GP or straight into a clinic. But for some reason, we can't do it at the moment. I think it's your end, isn't it? The technology needs to be married up with ERS. Exactly.
So we're about to launch that integration with ERS. So we've been working on it for a period of time, and now it's ready to launch. So yes, for exactly that use case, whereby you get advice. Either you want to convert that request for a 2-week wait appointment into a routine referral rather than a 2-week wait, or to accept it into 2-week wait. And with the integration, you'd be able to do that, and you'd be able to configure your service to do that just with one click. So from that drop down, it will convert into an ERS referral, which I think will be very powerful, rather than the advice just going back and then for a second step.
What we can do actually in secondary care is, if it's a non-lesion, or it is a lesion or a nasty rash, and the patient looks as if they have an urgent problem, in ERS there's not much you can do about that, but in Synapsis you can take a screenshot of one page, because it's all on one page, and then email that to our junior staff who cover an urgent clinic. So rather than make the GP have to refer again, we say, right, we'll take this on, we'll take the details, thank you very much, they'll be seen in the urgent clinic, and you click, and the junior then will then make the appointment directly with the patient. So you can bypass some of those steps at the moment still.
Yeah. Okay. So thank you. So we've got a question about consent. So the question is mine. Jim, do you want to take this? Shall I read it out? So the question is, my understanding was that written consent was required if images are used for teaching or training, as opposed to just clinical use. And has something changed? So Jim, do you want to take that?
Yeah, I think that's a really important one. So for most of what we're doing, we're getting verbal consent, and Synapsis lets us record that we've gained verbal consent for it. You're absolutely right that if we are using the images for teaching or training, certainly within primary care, it is definitely good practice to use a consent form. And the way I would normally do that is actually I have a written consent form which I get them to sign and take a photo of it and upload it into the clinical notes in the same way as all the other photos. So you can take a photo of a paper consent form and put it in there as a sort of workaround, because you're never going to have an electronic form that is as good as having a paper form that you signed. And the advantage then, of course, of having the photo of it is that you can give the patient the original and they can take it away and read all the details that you've got on that consent form as well.
Yeah, well, I think this question may have become, so in Synapses, when you take a photo, there is a prompt to check that, you know, the clinician has taken consent, and that could be verbal, as you say, you know, but it's kind of belts and braces, just that there's a record that process has taken place. But you're absolutely right that, you know, if you're doing it for the purpose of delivering care for that patient, then actually, you know, implied consent can work as well. And there are some circumstances where it's not possible to take consent, you know, and you have to do it obviously in the patient's best interest. And that's allowed, but we just cover that as kind of belts and braces in the software. So the other questions around integration to secondary care, and this is an area that we've really developed on recently, and we now have a means of integrating via what's called HL7 messaging with secondary care systems. So modern EPR systems, so all the ones that you know about, they accept this common language called HL7 or FHIR is the new iteration of it, and we were able to send structured data into secondary care systems, and we're working with a few areas to do that. Gloucestershire, it's on its way. I think you've recently, or in the last few months, really, just before COVID, I understand, have kind of been implementing Sunrise, which is a new system. So once that's bedded in, we'll be integrating with the trust system as well. So yeah, so I guess what the other thing was that we're interested in is, have you found that advice and guidance has changed kind of the relationship or the way you work between primary and secondary care? Has it kind of brought you closer, or is it kind of created new frictions that weren't there before? Well, Jen, what do you think?
Well, I think I've always had an excellent relationship with all the secondary care dermatologists, because they've kind of got used to me asking them questions over the years. I don't think they've really had any choice. But I think from an overall sort of perspective, advice and guidance is always excellent for that, because we're asking questions, we're getting to know the dermatologists are getting to know the GPs, and the sorts of questions and the sorts of questions they're asking and the sorts of people that they're referring. And I think, you know, there are huge educational benefits from doing it as well, and potential education benefits from doing it. Clearly, if you're trying to get through 800 a month, then there's not that much time to write great long detailed teaching bits. But actually, you know, there is always something to be learned, and there's always some pearl of wisdom to be passed on to us from these guys.
Great. And Bill, what's your take on it?
Yeah, definitely. I mean, you know, 20 years ago, we used to meet the GPs regularly in grand rounds and things, and have lots of educational meetings. And that's all gone. So I don't know many of the local GPs anymore. So this has reintroduced a connection, albeit a cyber one. There are still frictions, however. I mean, I totally agree with Chin that it's good for, if you're in the right frame of mind, it's good for education if you've got time to give decent feedback on an A&G case. But we do get a bit of advice and guidance fatigue at this end, because we have an awful lot to do, and it's very cold work. You know, it's fairly soulless at times. So I in particular often just give 1 or 2 line answers, which they may not like. So I think frictions are received that way, and GPs probably think I'm a bit of a surly sod. Maybe I am. And there is also the friction from our point of view that when we get just terrible pictures, just clearly the patient's been sent the picture in, the GP's thought, I don't know what it is, it's out of focus, and just send it straight on to us with a 1-line history, and you're thinking, you know, you're not making the effort here either. That's irritating. So if we don't get good images and some sort of history, we do get a bit narked, shall we say. But I think I can also irritate them with my 1-liners back. But on the whole, you know, A&G is a positive thing, particularly in areas where you've got larger rural communities that are a long way from hospitals, or elderly people who can't get around. So you know, it is definitely the future. Nothing we can do about it. We just got to embrace it. Great,
thank you. And Chin, one of the questions is around, you know, you said, you know, that Synapsis is not just used for dermatology in Gloucestershire, but actually used for a lot of other specialities. So could you talk a little bit about that and other ways that Synapsis is used?
Yeah, absolutely. I saw that someone had put a question there about the real-time use of Synapsis. So that's not used for dermatology, but it is used for all our acute medical admissions. And back in the old days, what we used to do was we used to phone the hospital switchboard, get them to bleep the person that was on call for medicine, for example, and then they wouldn't answer their bleep. So you get them to try the registrar, and if you were lucky, you might get someone to answer a bleep after you've been on the phone for about 15 minutes waiting and got, you know, lots of angry patients building up in the waiting room. And so with Synapsis from the GP end, basically what you do is you go through the process very similar to that dermatology one, except that you have an option of a number to phone, and you can either call directly or you can request a call back. But if you call directly, essentially what it does is it rings on one person's phone for 30 seconds, and if they don't pick up, it goes and rings on another person's phone for 30 seconds. And basically it just goes around the team of people until someone answers. And the team for medical admissions might be, I mean, sometimes it's up to 6 or 7 people. And that has a huge advantage, because then the person who is free to speak will take the call. And not only will they take the call, but they've got all of the patient details there. And the best bit, and the thing I love about it the most, I have to say, is that you can see the name of the person who's answered the call. And so instead of them saying, you know, medical reg, whatever, you can see their name, you can often see their photo. And actually that makes a huge difference in terms of building up relationships with a team in the hospital as well. So it's pretty much, it's the same as bleeping someone essentially, but you're bleeping 5 or 6 people simultaneously, and whoever is free answers it. And as a system for an acute medical take, that's enormously more efficient than trying to ask switchboard to manually bleep one person and then someone else if they don't reply, and you don't know if switchboard's forgotten about you, and you don't know if you've accidentally been cut off and things like that, which, you know, are things we will all be familiar with. Yeah.
And it's now used, so just used across a number of specialities, isn't it? So it's used for, you know, dermatology is one of the most popular, but acute medicine, acute adult medicine, pediatrics, trauma orthopedics, frailty, and it was used also, you know, during the different waves of COVID to provide advice and palliative care, and it's used by the ambulance service as well, so used across the board. So we're getting to the end of the webinar. I think we're at almost an hour now. So I just want to take just the time to thank, first of all, Chin and Bill for your time. Thank EMIS and Jamie for the opportunity to work together, and thank everybody for all the questions that we've had. We'll look through them. If we haven't been able to answer all of them, we'll look through them and revert with answers where we can. But yeah, so from Synapsis' point of view, we love working with clinicians. So we're very focused on trying to make things as easy as possible for clinicians in primary care, secondary care, community care, We're working across ophthalmology now, and in all different parts of the country. So we're very open to people contacting us and working collaboratively. So don't hesitate to reach out to either myself or one of the Synapses team. Thank you very much, Jamie.
My pleasure. I echo all the sentiments you just mentioned, and again a special thank you to Chin and William. Real pleasure listening to you. Thank you ever so much. So from everyone here at EMIS as well, have a great afternoon, everyone. We will circulate the recording and look forward to speaking to you again. Thanks a lot.